Opportunity to say hello to all the participants. I've got Professor Giovanni Di Giacomo sitting next to me, and now we have Pietro Randelli, Professor Pietro Randelli, Tai Lee, Bradley Edwards, and Philip Valenti. I hope you can hear me. Very good. Now, today we're going to talk about the evolution of shoulder surgery. And of course, this is something that is constantly changing, new techniques, less and less invasive techniques, and the results are better and better. Professor Randelli, I'd like to ask you this question. Over the past 10, 15 years, there has been an evolution in shoulder surgery. Can you say something about it? Thank you very much for this question. It's the right question given the topic of the evening. Well, the things that have changed, well, actually, many things have changed. In particular, shoulder surgeons, just like physiotherapists, physical and rehabilitation therapists, have developed a better knowledge of the biomechanics correlated with shoulder pathology. So, enormous steps forward have been made over the past 10 years, and this allows us to make a very precise diagnosis and to treat our patients in the best possible way. As far as technical innovation is concerned, the element that has really caused a revolution in shoulder surgery is reverse prosthesis. Reverse prosthesis developed at the end of last century, basically, in France, and also at the beginning of this century, 2001, 2002, 2003 in Italy as well. And then later on in 2005 in North America, and later on in advanced countries like Japan because of regulatory problems. Reverse prosthesis has completely changed the results of shoulder prosthesis. In the past, there were those who used to say that it was really the end. On the contrary, today we know that it can give very good results to our patients. A shoulder prosthesis in the past, we had 1,500 shoulder prosthesis 15 years ago. Now the number has gone up to 10,000. The numbers are lower than knee and hip prostheses, 100,000 each in Italy, but 10,000 prostheses of the shoulder is still quite a high number. And this shows that the prosthesis is valid and that the surgeons are valid as well. Giovanni Di Giacomo, anything to add? Well, first of all, I would like to take this opportunity to thank my dear friend Pietro Randella, and I would also like to take this opportunity to thank the my three friends that represent the excellence of shoulder surgery, and they represent the United States of America and Europe, two different continents. We have decided to create this scientific pattern focusing on reverse prosthesis, which today is probably one of the best types or best elements in shoulder surgery. As Professor Randelli said before, and as we have learned over the years, we now are able to make correlations between the efficiency and effectiveness of surgical techniques, interpreting them also in terms of biomechanics. So I think that today's discussion will clarify many things for the dozens of physical therapists and surgeons who are listening to us at the moment. Yes, and on this subject, I'd like to say hello to Professor Tai Lee, Director of Research of the Congress Medical Foundation in Pasadena, California, in the United States. He had his degree at the California University in San Diego, and he has a leadership role in many organizations and societies. And also, he is the scientific member of the ASEA. Professor Tai Lee, I'd like to ask you this question. From your own point of view, where are we going to get? What would be the results as far as shoulder surgery is concerned? We have heard that over the past 10 to 15 years, there has been an evolution. What will be the result of this evolution? What else can we expect in terms of evolution of shoulder surgery?
I think from mechanical perspective, I think concept is down. I think I think what we can do is really improve on tailoring to each patient's needs, and that comes from various types of implants as well as surgeon approaches. So I think focusing more and more on soft tissues, which provide function, which are the muscles, and I think tailoring to patients' needs. I think that's the future for next 10 years or so, because every patient is different.
Certo, assolutamente.
Yes, of course, patients are different, and as a matter of fact, we are moving towards a type of medicine and also of surgery which will be customized and personalized. And I would also like to introduce to speak about Rockwood Madsen, the book with the preface, the introduction by Dr. Giovanni Di Giacomo. For 30 years, this book is a benchmark in the assessment and management of shoulder problems and disorders. You see the cover page, this is the 6th edition, in line with the tradition of excellence under the supervision of the senior rapporteur, the very well-known shoulder surgeon Frederick Madsen III, together with the co-authors and co-editors Frank Cordasco, John Sperling, and many other authors and experts who come from the four corners of the world. This volume reflects and includes all the current knowledge, but also pioneering techniques are mentioned in the text, in the videos also, which are constantly updated, and they have been updated in this new edition. There also are prestigious articles in this book and a new layout that is simpler to read. Shoulder surgeons of different levels, but also trainees, students, and also physiotherapists will obtain an enormous advantage from studying this essential benchmark for all the people working in this field. Well, this is our Bible in a way. This is the 6th edition, but I think that many of us have started our profession reading this book. I've also had the pleasure of going to Washington State and to Seattle. I have had the opportunity to see Professor Madsen as a surgeon and also as a scientist. Thank you. Now, what's new in this volume, apart from the layout? Well, it has been updated, especially when it comes to the most recent techniques. Very good. Now, let's move on. I think the moment has come to let's start speaking about the reverse prosthesis, which has completely changed the fate of the shoulder to hundreds of thousands of people throughout the world. Dr. Di Giacomo, I'd like to understand, first and foremost, what is reverse prosthesis? Can you explain this as a non-expert? I'm not a surgeon, so can you please explain what reverse prosthesis is? And then we will explain it even better for all the people who are connected with us today. Well, I will start before giving the floor to the experts. There will be 3 presentations with a high scientific content in terms of biomechanics and surgery. So let's start with the first slide. So answering your question, how can we make understand people what reverse prosthesis is? This is the video we show our patients so that they can understand what reverse prosthesis is. Reverse prosthesis is called reverse prosthesis because you see the reverse shape of the humerus that is convex and it is concave, and the opposite as far as the scapula is concerned. Basically, you can see that the humerus can not shift superiorly, and the calf that is still there, and the deltoid in particular, will represent the engine which will make this articulation, this joint work. Today, reverse prosthesis, as you said before, has completely changed the quality of life for hundreds of thousands of patients throughout the world who otherwise would have been paralyzed or semi-paralyzed. Today, the reverse prosthesis is indicated in cases of irreparable lesions of the rotator cuff. It is also used in arthrosis that is associated to rotator cuff lesion arthropathy. And with very successful interventions, and also interventions on instability. You see, this is a typical case of iatrogenic arthropathy due to an element of synthesis which causes a problem to the glenohumeral space. Today, we will discuss reverse prosthesis because it is replacing the anatomical prosthesis also in the typical pathology that is osteoarthrosis. It's a very good indication of the reverse prosthesis. It's been very successful also in the cases in which the anatomic prosthesis or endoprosthesis were successful for treating the proximal third of the humerus. Today, reverse prosthesis is used in complex fractures with 3-4 fragments, also in the acute phase with very good results. So we can say that from the clinical viewpoint, it's really successful, and the reverse prosthesis is successful when it is used in the cases of the proximal third of the humerus that had already been treated surgically. I've invited 3 speakers in order to better understand from the biomechanical point of view how to implant a reverse prosthesis. We can work biomechanically on the scapula, medializing or lateralizing, placing the glenosphere, the inferior tilt, or also at an angle. And so, I'm sure that all the specialists who are listening to us now, or the students also, can clarify how to actually position the glenosphere. If you love this topic, you will know that, of course, there are specific parameters, criteria that the surgeons have to follow. There are criteria who tend to in order to correctly orient the base plate, they use the beta angle. Other surgeons, thanks to Pascal Boileau, they tend to position the base plate, the glenosphere, in order to avoid notching at a lower position. But of course, this is something that will be clarified listening to the presentations, because there might be problems on the orientation of the angle. On the left, you can see an anatomic angle that measures the degree of tilt, inclination of the glenoid, which is useful for the application of an anatomic glenoid. The angle probably has to be assessed in a different way. The reverse shoulder angle, RSA, in the case in which, in reverse prosthesis, we want to position a lower base plate. You can see that the tilt of the lower portion of the glenoid that runs between the point R and the point S is tilted superiorly, unlike the central part with different degrees of inclination. So the surgeon must know these elements in order to try and avoid positioning the base plate, the glenosphere, with a higher tilt, which in the end might lead to biomechanical problems. In particular, there might be an immobilization of the scapular component. So the question I will ask my friends will be, how do you position the glenosphere? Do you medialize, so the center of rotation on the bone, or, according to different studies, it is better to lateralize the glenosphere with the center of rotation more lateral? And the inferior offset, in order to avoid the notching, the inferior offset, is it always complied with? Is it necessary to comply with this also when you lateralize the glenosphere? And what do you think about the tilt, the inferior tilt? What should it respect? So, the point of anchorage of the base plate, should it be parallel of the to the SS fossa? This is something that we all would like to know, and physical therapists as well, who are passionate about this topic, are particularly interested. And I think it is important to understand these surgical points and the clinical points with the good biomechanics. And I think it is essential to understand all of this in order to try and improve the results of our surgery. As far as the humerus is concerned, there is discussion in the literature how to position this stem, varus, valgus, lateralize more, lateralize less, with the inlay-onlay techniques. thanks to some prosthesis, how can we take advantage of the humeral component? You see, there are different patterns according to which there might be the medialization or the lateralization of the glenosphere, and also the medialization or lateralization of the humeral component. From different biomechanical studies, we know that the mediolateral pattern, that is, to position a glenosphere medial with the center of rotation on the bone and lateralizing the humerus, leads to good biomechanical advantage because it increases the torque, the moment arm, but at the same time, by lengthening the cuff that is remained and by lengthening the deltoid, we are not respecting the Bliss curve, that is the length of the muscular fibers. The length of the muscular fibers, which can be respected with what we call today the reverse anatomical. When we use a lateromedial pattern, that is, we lateralize the center of rotation, as it is the case in the normal shoulder. And this is an example of what I'm talking about. This is the left shoulder. You see the center of rotation in an anatomical shoulder, which is at the center of the head of the humerus. The geometrical center is the shift on the three planes of the humerus. This is the arc, the range that is ideal during the movement of the fibers, the length of the fibers of the deltoid. We use a mediolateral pattern. You see that the deltoid fibers are lengthened. If we lateralize the center of rotation, if I place it closer to the center, the anatomical center of rotation, you see that the fibers of the deltoid come closer in terms of length to the anatomical ones. So if we want to have more anatomical prosthesis, in compliance with the length of the muscular fibers, we need a lateromedial pattern. And the same applies to the axial plane. This is a normal humerus with the center of rotation. It is the excursion of the rotator cuff. If we use a lateromedial pattern, we have this type of green curve. If we use a mediolateral pattern, which gives a biomechanical advantage, but it does not respect the Bliss curve, we have fibers that during intra and extra rotation are under stress. There is a considerable strain. So the lateromedial pattern on the axial plane keeps the fibers of the cuff and of the deltoid closer to the anatomical ones. So one of the questions we're going to ask will be, which pattern do you use? Medial, as Professor Grammont taught us, or do you prefer to shift to a different pattern that is a little bit more anatomical from the biological viewpoint, that is lateromedial? Or do you prefer the moment arm with a medial glenoid and lateralizing the humerus? Or maybe you prefer to lateralize the humerus and lateralize the glenoid as well. So which pattern do you prefer? This is the question. So can you please justify from the biomechanical, biological point of view why you prefer the pattern you prefer, and also considering the different surgical indications from the sequela, from cuff arthropathy, do you change pattern as a function of the pathology that you have to deal with? And then the glenoid, it would be nice to understand where do you position the guide wire that represents the best plate? Do you place the best plate, as Pascal Boileau tells us, at the inferior level with a post parallel to the supraspinatus fossa, or do you prefer to place it higher with a post parallel to the supraspinatus fossa and lateralizing the glenosphere, trying to have a more anatomical prosthesis? So these are the things to be discussed from the biomechanical point of view. There are many things to discuss. And also, what do you think about the lateralization of the glenosphere? Do you all think that it is useful to lateralize the glenosphere? What about the inferior offset? Is it really indispensable when you lateralize the glenosphere in order to avoid notching? And also on the humeral side, we're going to ask you whether you prefer a 135 or 145 degrees angle, always in order to improve stability and the range of motion, avoiding notching. So inlay versus onlay. And also we would like to hear the biomechanical explanations for your choices. And finally, at least the last question I'd like to ask you, considering that the most complex part of prosthetic surgery is the exposure of the glenoid, in particular in the cases of revision. You see, this is a right-hand shoulder seen from the side. Well, you are expert surgeons. Do you have to give any tips and tricks in order to expose the glenoid? And after performing the osteotomy of the humeral head, do you prefer to perform subluxation of the proximal third of the humerus in extra rotation or in intra rotation? This is a right shoulder seen from the front. Performing infra rotation, you see the axillary nerve highlighted by the yellow lace. It might be under tension. So you prefer to perform subluxation of the proximal third of the humerus, and how to avoid the problems to the brachial plexus, which might be one of the complications in our surgery. So I'd like to invite the first guest, Professor Lee, who has already given us a brilliant introduction. So I'd like to give you the floor, Tai Lee. Professor Lee, you have the floor.
I think I'm going to go ahead and share my screen.
Noi la sentiamo, Noi la sentiamo se parla. Sta condividendo lo schermo?
Sì.
Okay. For some reason I'm not. Okay, now I see it. Let's see. Do share screen again. Can you see my screen?
Professor Di Giacomo?
No.
No, unfortunately not. No, we can't.
Share screen.
Ecco.
Can you see?
Stiamo riprovando la condivisione dello schermo.
So now we can button. Perfect.
Okay. Let me get.
Okay.
Okay, something happened here. Let's see. I'm not seeing my presentation again. Escape and try this again.
Il professore ha perso la presentazione.
Vogliamo passare al prossimo ospite che è il professor Bradley?
Now we're good.
Bradley è...
Ah no, è andata, perfetto. Thank you.
Can you see
and hear me
okay? Okay.
Yes, we can. Yes, we can.
Okay. So it certainly is a pleasure and honor to be here on Shoulder Channel TV. Very good and excellent introduction, giving us an idea about reverse shoulder arthroplasty. So these are my disclosures. So today I was asked to talk about reverse shoulder arthroplasty and TSA angle, RSA angle, and effects of glenosphere position and orientation with respect to supraspinatus fossa. Some of the debates that are going on between medial, lateral, and all the positioning, I don't think any one is better than the other because everything has trade-offs. And I think it's very important for surgeons to understand the effects of these choices and what they do to the shoulder. And as I spoke briefly earlier, all the individual patient is different and the needs are different. And you can use all this relationship to provide the best treatment possible for your patients. Okay, so to understand reverse shoulder, I want to go back to normal shoulder. So shoulder, as we know, that it has the greatest range of motion in the body and is stabilized by passive and active stabilizers. And complex interplay has to occur between these stabilizing systems for your shoulder to work properly. And it's also important to understand that injury to one affects the other. And rotator cuff and other deltoid and pec and lat are also very important because in reverse shoulder arthroplasty, typically you're dealing with cuff deficient shoulder. And what reverse shoulder arthroplasty is designed to do is compensate for these missing items. So in a normal shoulder, you'll see motion like rolling, sliding, and spinning. And then when you put all this together, if you look at rotation, you get this complex path of articulation. So how does this relate? Okay, I'm trying to go on to it. So how does this relate? So for anatomic shoulder arthroplasty, you're replacing the articular surface of the shoulders. So all the soft tissue are intact, and it allows rolling, sliding, and spinning to provide you with large range of motion and also stability. But when it comes to reverse shoulder arthroplasty, it's a semi-constrained articulation. And by having it semi-constrained, you increase the stability by about 4 times. So that's, you would think that's good, but it also comes at a price. It is designed to improve function of the remaining muscles. So you're providing stability with the implant design. The cost is that reduced range of motion, and also you increase the bone and implant interface stresses, so the stability gets affected. So you only get spinning alone, and you can think about how that is compromising your range of motion because you're not allowing it to translate. So surgeon challenges, as from scientific perspective, are all these choices. There are 2 basic designs out right now, which is medialized and lateralized, and it's up to the surgeons to pick which ones and where to position it. And you also have to, obviously, you have to get very good implant fixation. And soft tissue management becomes a challenge because you want to maximize the muscle function of the remaining muscles. So what I like to think about this is, assuming that your fixation is good, I like to think about it from impingement-free range of motion and muscle function. Impingement free range of motion, I like to think about a range of motion cone. This is not, the cones are not drawn to scale for actual range of motion, but you have external constraints, which is up at the acromion and also at the scapula neck. So you have external constraints that's going to limit your range of motion. But if you take the center of rotation, medialized or lateralized, this cone shape will change. So as you go out more, your external constraints are becoming further away, so you improve your range of motion. But you also have to think about this from muscle function, the deltoid function, and the remaining cup muscles. If you want to maximize it, you want to put the origin and the insertion back to where it was best as you possibly can, so you can maximize this muscle function. So total shoulder angle and reverse shoulder angle. I think both from engineering perspective, as long as you have good reference axis, you can compensate for it. But if you're going to determine the level or the orientation of your resection, then reverse shoulder angle is critical, I believe. And because this is specific to the reverse shoulder arthroplasty base plate. So you can see TSA angle as shown in the introduction. It underestimates the superior inclination for reverse base plate because reverse base plate is on the inferior half. So if you want to correct this and align all the muscles back to where it was, then reverse shoulder angle would be more appropriate. So again, center of rotation, position, and orientation, it is critical and it is controlled by surgeons. And this is my personal opinion, I don't think surgeons should just go with one design and one approach. This is what I believe in. But I think patients are different and needs are different. And so if you understand the relationships, you can choose the right design and right positioning for a particular patient. So what are the main effects of this inclination from total shoulder angle and reverse shoulder angle? Basically, if you use the total shoulder angle, you're going to point the glenosphere superiorly. As you can see on these diagrams, if you go superior, you crowd the subacromial space, and also you expose more of the glenoid neck. And that can result in decreased range of motion, scapular notching, and risk of component loosening. This picture on the right shows that with the circle with superiorly oriented, you can see the base plate stress profile is different and it's not at its good position. So this is a schematic diagram trying to illustrate what happens when you get the superior tilt and lateralized glenosphere. Basically, what you're dealing with is you're moving the articular surface, which is in red, pointing more superiorly. And by doing that, if you have medialized center of rotation, you're going to move the center of rotation down and more laterally. And if center of rotation is maintained, then basically you're changing the orientation of the articular surface. If you lateralize it more, center of rotation will go up and more medially, and lateralize it more, the effect is a little greater. So this is a complex picture, but top row is the same as I described, but also looking at from cone perspective, cone range of motion perspective, you can see what's happening, moving the center of rotation in or out, and also tilting, because you are constrained by the external boundaries or external constraints of the bone. So by moving center of rotation in or out, you can definitely affect range of motion and implant stability. So what about inferior offset? Inferior offset, you can describe it using the same principles. Inferior overhang will decrease impingement-free range of motion from its ideal position, and also decrease implant stability. So the important thing about inferior offset is that it helps to negate some of the superior inclination of the glenosphere, but it does not do it completely. So it does help it, but you also have to think about implant fixation when you position your glenosphere. So this is, to me, this is a very good way of thinking about effects of medialization or lateralization or base plate position. So the TSA angle, as we talked about earlier, it considers the entire glenoid fossa. So it is appropriate for total shoulder arthroplasty. For reverse shoulder arthroplasty, it underestimates superior inclination. And the reverse shoulder angle, the arthroplasty angle, is more appropriate for reverse shoulder because the base plate is placed on the inferior portion of the glenoid. So today, RSA designs, there are lots of them out there, medialized, lateralized, glenosphere size, shape, and offset. It's up to the surgeons to choose what's appropriate for your patient. For example, if you lateralize the component too much, you're going to really increase the interface, bone implant interface stress. And if you medialize, that stress will be less. But you also have to think about the positioning and the muscle force directions or muscle tension relationship. So all these are under the control of the surgeons, and it's really important for surgeons to understand the relationship of what's happening. And you can choose the appropriate implant and place them accordingly. So again, going back to this cone range of motion, because we have a constant center of rotation that's not moving. And so this is a very good way to think about it. Every time you move the glenosphere, that is going to be affecting this cone. And as important is muscle function, because you're trying to restore the function on the patient. And the deltoid and remaining rotator cuff muscles, you want to make sure that their length tension relationships is restored best as you possibly can. You can do this with the glenosphere. You can also do it with humeral component. So all these things come into play. It's not just the implant fixation and the glenosphere orientation, but you have to think about the muscles that are working afterwards. Thank you.
Perfetto, grazie mille, penso che è stata
Thank you very much. I think that this was a very good introduction because, of course, there are very interesting works published by Mark Frankel, who was one of the promoters of reverse prosthesis in the United States of America and one of the supporters of the lateral medial pattern. He introduced the concept of lateralization of the center of rotation and also the geometric center. So having the center of rotation closer to the geometric center means trying to have a prosthesis that maintains the length of the muscular fibers, what we call the anatomical reverse prosthesis. And I think that this is a subject that our friend Edwards, Bradley Edwards, loves. Professor Bradley Edwards,
yes,
specialized in the shoulder studies, and of course, he is recognized globally as an expert in this field. And of course, he's been dealing with all the problems of the shoulders, the ones treated with open surgery, arthroscopic surgery. He's very active in clinical research and in scientific research. He has published more than 100 scientific papers and 10 book chapters on topics like rotator cuff problems, shoulder instability, and also shoulder replacement surgery. He has written books about shoulder replacement and shoulder arthroscopy, and also he has made more than 100 scientific presentations in national and international conferences. So we would like now to hear from you what your point of view is. What is your surgical technique on this subject? You have the floor, sir.
Thank you. I will share my screen here. Thank you for the kind invitation to participate in this international TV channel. Yeah, so Ty Lee did a great job going over the basic biomechanics of reverse shoulder arthroplasty. And then what my talk is going to attempt to do is show you how I've used those biomechanics and their clinical correlation to the results I'm getting and what I've changed over the years. I was fortunate enough to do my fellowship in Europe before the reverse prosthesis was available in North America. So I was one of the North Americans that got the earliest experience with it. And certainly things have changed a lot in the last 20 years. So my disclosures are here and they are relevant to this talk in that I have royalties on some different reverse designs. So as I mentioned, my initial experience with reverse shoulder arthroplasty was during my fellowship with Gilles Walsh in Lyon. And Gilles, like everyone at the time, was using the Grammont design, which was an inlay design with a 155-degree neck inclination angle. The glenoid was medialized center of rotation, and because of the inlay nature, it was a medialized humerus. So this was what we now would refer to as a medialized design. Although I did this design in my fellowship, it was not available in North America until around 2004. And you can see my results on my first 100 or so arthroplasties, reverse arthroplasties using a Grammont implant are here, which reflected the experience that was being seen in Europe. Of note was the external rotation, which did improve, but it was very dependent on the presence of posterior rotator cuff tissue. So if you did have some teres minor or infraspinatus present, you got much better external rotation. If you did not see any appreciable improvement in external rotation using a Grammont design. Scapular notching, as mentioned, was seen frequently with this type of design. In our series, it was 88% at 2 years. It did not seem to progress beyond 2 years, but it was somewhat concerning and something maybe we should try and eliminate. So if we had results that we had never been able to achieve before in cuff arthropathy patients using a Grammont medialized design, why should we change? Well, we changed mainly for the ability to have a convertible stem. So our thought process when we were designing our next arthroplasty was to have a short stem design to make use of metaphyseal fixation, and also be able to have the same basic stem design for an anatomical reverse. Now, initially, we sought to achieve this with an inlay humeral component, which was modular down in the metaphysis. However, because of perceived regulatory issues we would face in the United States, as well as the fact we didn't know that there would be any major issues with an onlay design, we changed to an onlay to simplify the actual prosthesis. So what this did for us, we kept the Grammont medialized glenoid and inadvertently lateralized the humerus by using an onlay. We were not trying to get a lateralized design. It's just that was a consequence. And you can see here versus an inlay, which more medializes the humerus, an onlay will lateralize the humerus by setting the concavity of the humeral component on top of the cut surface as opposed to within the cut surface. And our results with this medialized glenoid lateralized humerus were certainly quite good. These are our early results of this particular implant. And you can see the constant score improved as expected, very similar to the Grammont. But we did see better post-operative flexion and abduction, and also better external rotation, independent somewhat of the presence of infraspinatus and teres minor. So in other words, by using this lateralized design, we did see better external rotation, presumably from tensioning the posterior deltoid fibers, even in the absence of posterior rotator cuff. Scapular notching did decrease as well to 20% from almost 90%, with really no severe notches present at almost a year and a half afterwards. However, there were some negatives to this as well. 10% of my patients had inexplicable pain. So we couldn't really see why. The nerve tests were all normal. Nothing showed up on further imaging studies. And I probably relate this to maybe excessive arm lengthening, which we saw with this onlay humerus that we were not seeing with the Grammont. Additionally, we saw 4 to 5% scapular spine fractures, which with the Grammont, it was 1 to 2%. So even though we got better mobility and had a convertible stem, there were some trade-offs here that were not really favorable in our results. And what we finally perceived at this point is that we were actually lateralizing the whole construct. And there are different ways to lateralize and different concepts here. So if you look at here, you see the Grammont medialized. Then what we did with a lateralized humerus, not even recognizing we were lateralizing first, and a medialized glenoid. Then we used for a while Pascal's technique with a Grammont, lateralizing the glenoid with a bio-RSA, but still medializing the humerus. And then you can see Mark Frankel's design, where he lateralized the glenoid with metal and with a more lateralized glenosphere and not with bone, but had a medialized humerus. And then you finally can do the extreme where you lateralize. Here you can see a bio-RSA I did to lateralize the glenoid, and then a lateralized humerus. And you can look at the relative position of the greater tuberosity to the lateral acromion and see how much we actually lateralize here. So what these lateralized designs decreased notching and by and large increased external rotation. So Mark Frankel came to visit Gilles in the 90s, and he saw the Grammont, and then he did not like the impingement he saw medially and the notching. So he decided to lateralize his glenoid component and still use an inlay humerus. He also used an anatomic inclination angle when he did this as opposed to 155 degree. And his whole concept early was to avoid the notching and impingement. And certainly if you look at the results of the Frankel design, which was lateralized glenoid medialized humerus versus the Grammont's medialized, they both had 90% survivorship over the long term, 9% notching versus 90% notching. But the big difference is in the Grammont design, and this was observed by me and then many other authors, there was a deterioration of results around 6 to 8 years where you'd see constant scores going down. However, you did not see that in Mark Frankel's design at 10-year follow-up. So the results were comparable, but it seemed like the long-term results were more reliable with a lateralized glenoid medialized humerus. And so what I've done as I've kind of gone through these iterations of the reverse, and I've kind of tried them all, as you've seen from my experience, I've migrated to the lateralized glenoid medialized humerus, but not just stopping there. I definitely am now moving more and more forward with my exploration of the anatomic reverse. Early on, we were just trying to tension the deltoid to make sure that we got the deltoid to fire and provide elevation. But that did come with a cost. Some patients with pain, going beyond Blick's curve, getting deltoid fatigue, and that may lead to our deterioration of results that have occurred at the 10-year, the 6 to 8 year follow-up. So now I'm trying to aim for this that you see here in this x-ray here, where you see the Shenton's line of the shoulder is essentially normal or pretty close to it. And I'm doing that with a lateralized glenoid, a medialized humerus. I'm placing my glenoid component mainly in the center of the glenoid as opposed to the inferior portion, because with a lateralized glenosphere, you don't get the impingement here and the notching. And I think that what this does is it more closely restores normal glenohumeral and soft tissue relationship. So it will more properly tension the posterior rotator cuff. It will more properly put the deltoid at its normal length. So the purpose of the rotator cuff is to provide a fulcrum. And what we're trying to do with this is to provide the fulcrum with the reverse that the rotator cuff can no longer do. So we want to keep the deltoid at its normal tension as if there were a rotator cuff. So now what we can do is take our cases and, it's like, well, how do you do this? How do we really execute this? How do we know what we're doing intraoperatively? Well, a big part of this, and this is just a representative case, you can see this is actually an osteoarthritic patient with 40 degrees of retroversion. We can look at soft tissue planning software now, and it will show us what the patient's native premorbid scapula should look like. And this is using algorithms, a lot of which were based on Joe Ionati's work with the vault model. So we can take the software and we can say, okay, this is what the patient's premorbid anatomy should look like, not just on the axial, but also on the coronal cuts. And so we can take it, and now we can say, okay, I want to do an anatomic reconstruction no matter what I'm doing. So if I look at this case and I say, well, maybe I can plan this with an augmented glenoid, but with 40 degrees of retroversion, I know that we're probably not going to be successful doing that. So if you ask me, do I reference for tilt the RSA angle or the TSA angle, the beta angle? What I reference now is the patient's premorbid anatomy, and I'm trying to restore my tilt and glenoid position based on restoring where their normal joint surface would be. So if you look here, instead of medializer and putting the patient in excessive retroversion, I'll use a bone graft, try and get my glenosphere to position my joint line where it should be. And then the next step, of course, is to actually use preoperative planning software to not just plan the glenoid position, but also to plan the humeral position and try and obtain planning that will allow us to get the anatomic reverse prosthesis. And that's really what my goal is going forward. So at this point, 20 years into my use of the reverse prosthesis, my ideal reverse is an inlay humerus with a 135-degree neck inclination angle. I think that reduces notching. And the other thing is it lets me make the same cut, essentially, whether I'm doing an anatomic or reverse. I can think about shoulder arthroplasty as shoulder arthroplasty as opposed to anatomic or reverse shoulder arthroplasty. I like the use of a short stem because metaphyseal fixation, I think, is about all you need. On the glenoid side, I use a laterally offset glenoid, doing that with metal. In general, I use a 6 millimeters lateral offset. However, that is changing based on our ability to plan this out and to get the patient's anatomy restored to what it was in the premorbid state. I position my glenoid at the center for some of the reasons I've talked about. So in summary, I think inlay humeral designs are associated with a lower rate of scapular spine fractures, and that's a big reason I went back to them. Lateralized glenoid designs are durable and are associated with improved external rotation and less notching and impingement. And the anatomic reverse has become my goal in shoulder arthroplasty. I think the anatomic reverse better restores the normal soft tissue relationships, whether that's some posterior rotator cuff that might be present, but of course the deltoid, where you're putting that where it should be positioned and not maybe excessively tension in it. The anatomic reverse in my hands is best achieved with an inlay humerus and a lateralized glenoid centered on the glenoid surface. Thank you very much for your kind invitation to speak at this event.
Grazie.
Grazie Edwards, ti ringrazio.
Thank you very much, Edwards, because you really focused on the topic. I'm really fascinated. I myself, I'm perfectly in line with your philosophy, also thanks to Mark Franco. So the concept of performing an anatomical reverse by respecting as much as possible the shape of the shoulder, and in particular the biomechanics and the biology of the muscle is, for me, the key, the direction we should all be heading for. Now, let's cross the ocean and let's talk to Philippe Valenti. What do you say in France? What do you think in France about these patterns? Can you clarify the ideas you have in France? And we have to recognize that in France, the reverse prosthesis was born. So, of course, you have a structured experience over the years. What is your message from France?
Yes, thank you very much, because we are lucky to know Gramont, and we work with Gilles Valch in 1990. And the reason why I would like to share my screen.
Per il cappello. Ti faccio I complimenti.
Congratulations for your hat. Your hat is wonderful. It's fantastic.
Yes, sorry.
Sì, è vero. Ma era in sala operatoria?
Were you in the OR?
Yes, I am in the OR, because I want to listen
Perché sì.
on Dr. Lee and Dr. Bradley. Very nice topic, and thank you very much for shoulder channel, because it's a very good education for anyone, surgeon, doctors, physiotherapists. So this is my experience, because I started reverse orthoplasty in 1990 with Gramont prosthesis, and I would like to show you how we progress for the patients. This is my disclosure. It's important to remember that the Gramont prosthesis is a straight humeral stem with 155 degrees of net shock angle. This is an inlay humeral liner. This is an inlay glenoid, inlay glenoid, and the glenosphere is alpha sphere. And there is a medialization and distalization of the humerus. So you see, this is my first case. You see on the left side, the center of rotation. If you do a Gramont prosthesis, you medialize and you distalize the center of rotation, and you increase the lever arm of the deltoid. You increase the tension of the deltoid, and you restore active forward elevation. This is a biomechanic concept of the Gramont prosthesis. So if you use that, you have a price to pay, of course, of too much medialization, because as described by Bradley, you see that 90% of scapular notching, you have no improvement of external rotation, you have a limited internal rotation, you have a high risk of instability, and you have a loss of shoulder control. So you see that it's a standard Gramont prosthesis. You have an impingement of the polyethylene socket to the scapula. It's clear. You have no recruiting of the posterior deltoid, and you have a slackening of the residual cleft. It's clear that biomechanically, you obtain a limited external rotation, limited internal rotation, and the risk of instability if you use the biomechanical concepts of standard Gramont. So if you, it's too stop. So if you want to optimize the function of the Gramont prosthesis, you have to maintain the distalization, because it's very important for the deltoid, but you have to increase the lateralization. And with Jean-David Bertel, we did a very nice job we analyze all the prostheses and we measure the lateralization in the glenoid component, in the humeral component, and the distalization in the glenoid component and in the humeral component. So today we use a lateralized glenoid component, but we have to respect the rules. Flush to the inferior glenoid. You have to put inferior tilt, and RSA angle is very important, of course. Thank you, Pascal. But now with the software, we can measure the RSA angle. This is a relative angle, or you can use a bone graft to obtain an inferior glenoid tilt. And in my experience today, I put more retrobation to avoid impingement with the conjoint tendon. And I think that the stability is better with 5 to 10 degrees of retrobation. So if you lateralize the glenoid component, and more important for me, if you lateralize the humerus, you increase the strength of the posterior anterior deltoid, you increase the tension of the deltoid, you increase the tension of the remaining cuff. And when you have only the teres minor, you increase the tenodesis effect of the teres minor. So it's clear that biomechanically, if you lateralize the glenoid component and if you lateralize the humerus, you have more strength. So you can measure, it's easy. You see that this is the aeroprothesis and it's very lateralized. We lateralize in the glenosphere and we lateralize in the glenoid. So in 2003, we implanted a lot of Grammont prostheses with the complications, and we, in the same period, we described 3 techniques to lateralize. Mark Frankel, he lateralized with a 2/3 sphere in the glenoid component. Pascal lateralized with a bone graft. This is a BIO-RSA. And we decided to lateralize with a metallic base plate lateralization. And you know very well that regarding the shearing forces, if you lateralize less than 1 centimeter, there is no risk regarding the glenoid loosening. So 1 centimeter is the limit for the lateralization of the center of rotation. And you can increase the lateralization with the big glenosphere. So if you talk about the lateralization of the humerus, you see that you can use a straight. And now this is the evolution, because if you use a curve, you lateralize too much. And regarding the nerve shaft angle between 155 to 135, and the evolution is in the middle, 145. And regarding the humeral insert, you can use a medial position, lateral position. If you use inlay, is of course less lateralization than onlay, or you have the possibility to lateralize with 5, 10, or 15 millimeters. So a long time ago, in 2009, I published this paper because I compare 47 delta with 49 aeroprothesis, lateralized prosthesis. And it's clear that if you lateralize, you increase external rotation and internal rotation. And I didn't increase the forward elevation because I think that forward elevation depends on the deltoid. So it's a long time ago, you see that 2009. So distalization, glenoid humerus, you see that you can distalize with 155 degrees, nerve shaft angle, polyethylene spacer, overhang, glenosphere, inferior tilt, but you have a limit of overhang, because if you put a overhang or too much distalization, you have a risk, particularly on all the patients, nerve stretching, radial nerve stretching, and brachial plexus stretching. Particularly when you have a Hamada 5 and you decide to distalize, take care, because if you distalize 3 or 4 centimeters, sometimes you have a stretching of the radial nerve of the brachial plexus. So today it's clear that if you want to summarize, if you lateralize your prosthesis, you increase external rotation, internal rotation, and no notch. if you distalize the prosthesis, for example, in cuff tear arthropathy, you restore forward active elevation. And the main issue today is what is the best combination for each patient? Because this is the key point today. I think that there is no problem to implant the glenoid component, to implant the prosthesis. You have a lot of design, but what is the best design? Depends on the deltoid. For example, if the patient was operated 2 or 3 times with a thin deltoid, depends on the residual cuff, depends on the size of the patient, because where do you implant for small patient, on big patient? Do you do RSA for small patient? No, certainly no, and depends on the stiffness. So I think that this is my practice today, because Johan Bartsch in Grenoble did a very nice job, and he described 2 angles, the LSA angle for lateralization and the DSA angle for distalization. And he compared patients with a good deltoid on cuff arthropathy. And he talks that there is a range of 20 degrees of LSA or DSA to obtain good external rotation, but there are limits. If you distalize too much, you decrease forward elevation because the deltoid is too tight. And take care, if you lateralize too much, you decrease the external rotation. This is an example. You see that the patient is limited in forward elevation because the distalization is too much. There is a negative correlation on more distalization, less lateralization. So if you read the literature, this is controversial. Some authors say, well, yes, it's important. Some authors say, no, it's not important. There is no consensus regarding the distalization and lateralization. So I asked to my fellow and the 3 independent surgeons on 2 times to measure on my patients. And I selected patients for cuff tear arthropathy and good deltoid. I excluded revision, reverse and tendon transfer and sequelae. I use the same prosthesis, the same surgeon. You see that is the lateralized prosthesis. And this is the results that we selected 2 groups of patients. We see that we measure the LSA angle at between 70 and 90 degrees, and we can measure with the software today. It's very important to measure on the software lateralization and distalization. And in my theory, I think that the best result for this kind of patient is with a LSA angle between 70 to 90 degrees. If you increase the LSA, you see that you decrease the external rotation, you decrease forward elevation, and you decrease constant score. It's the same for DSA, and we measure and we select the group of patients between 40 to 55 or 60, we have the best result. If you distalize less, you lose forward elevation. If you distalize more, you lose forward elevation and external rotation. So regarding the inferior tilt, with this prosthesis, we recommend inferior tilt because if you lateralize the center of rotation with the inferior tilt, we have a good compression for the bone graft and we decrease the shearing forces. And regarding the active forward elevation and external rotation, we found this between inferior tilt 5 to 10 degrees. And we can do it on the perioperative planning. So we have a limit in the true life because sometimes the patient is small, soft tissue contracture. If you lateralize too much, it's difficult to repair subscapularis, to reduce the joint. And there is limit for distalization for Amada 4B or 5. And if you use only and you distalize, there is a risk of fracture of the acromion on spine. So it's not so easy in the true life to reproduce the planning. So today, in my practice, regarding cuff tear arthropathy, there is no cuff. There is a good deltoid. I try with my software to obtain a LSA angle between 70 to 90. And I try best distalization is between 40 to 60. And if I have no this angle, I change my component to reproduce this finger. The software for me is a key point today for all the surgery. So you see that this is a software. You see that it's very easy. You have preoperative, you have postoperative, you have preoperative, you have postoperative, and this is automatic for distalization and lateralization. So today, if there is a curve arthropathy, weak deltoid, small patient, I prefer to distalize, and but I lateralize more than Gramo. And this is for me, we have to be close to Gramo, distalize, but you have to lateralize to increase external and interrotation. But you know that in the glenoid B2, C, functional curve, you have to do anatomic reverse shoulder arthroplasty. And I am completely agree with Bradley. You have to reproduce to the lateral offset, but don't distalize. It's not necessary. You have a strong deltoid, you have a functional curve, you do a reverse, but you put the reverse close to the anatomy shoulder arthroplasty. So today, with this prosthesis, if we, I prefer angle because depends of the size of the patient, but 40 to 60 degree of distalization is 3 centimeter, on 70 to 90 degrees of lateralization is 5 millimeters more than preoperative. Thank you for your attention, and I invite you for the next meeting, and we will talk many times. On the Wednesday afternoon, we have an update software with Gilles Balch on all the company, all the leader, explain the software to prove that it's very useful for the patient today. Thank you very much.
Grazie, grazie.
Thank you.
Filippo Valenti.
Thank you very much, Philippe Valenti, orthopedic surgeon, very well known throughout the world. I would like to remind you that he's the founder of the Center for Man. I hope I pronounced it correctly, of course not. And this is one of the largest centers in Paris with 7-8 specialized surgeons. He's also the chairman of the French Academy of Orthopedic Traumatology. Thank you very much. So, Pietro, I'd like to ask Pietro, because we have had plenty of biomechanical and clinical information, and I think it is nice to see that the conclusions of two very important specialists on two sides of the world were all moving in the same direction. In particular, Philippe has shown us that when the deltoid is strong, we try to reproduce the anatomy. What nature did is probably always the winner. This anatomical reverse, trying to lateralize the center of rotation and to have a geometric center similar to the anatomy, is the winner. Pietro, do you have any questions? Yes, of course, because today we are speaking in general terms of lateralization, but the problem is how much to lateralize, and also what is the limit.
So, in other words, we speak about lateralization, how much we do need to lateralize, and what measure we should not exceed in lateralization that can be detrimental in your experience.
I can start, I guess. I agree with Philippe. If you start lateralizing more than 1 centimeter, I think you are risking glenoid failure. Now, things have changed a lot. If you look at Mark Frankel's early work, he had a 10% failure rate on his first lateralized glenoid component. But what changed on that is the fixation changed as he used locking screws and larger screws. And I think as we advance our fixation technology on the glenoid, that's allowed us to lateralize more and more. So today we're saying 1 centimeter is the limit. Maybe it will not be the limit in the future. So I think what we still need to shoot for is, if we use the planning software for whichever company you choose, if you can take that information and say, this is where the patient's native center of rotation should be, And then you see that not just on the glenoid side, but on the humeral side, it will tell you how much you should lateralize to get that patient's anatomy optimized, even with a reverse.
Philippe?
Yes, I agree with Bradley. For me, the glenoid component is not an issue today. I put 1 centimeter of lateralization to avoid glenoid notch and to avoid impingement. It's the reason why I do a little retrogression on inferior teeth to avoid impingement with the acromion. The decision today is how do you lateralize the humerus? On which component to use? For example, if you want to reproduce the anatomy and you use a Neff shaft handle 155 degrees, is a mistake. If you want to reproduce the anatomy, I think that you have to use 135 on probably an inlay with a lateralization of the humerus. And I am agree with Bradley. This is a patient with a B2C with functional cuff, good deltoid. And the goal is to put the center of rotation of the reverse close to the center of rotation of the anatomy. And you have to choose the best design for that. This is the first point. And I think that is the easier point. The difficult point is that we have a cuff tear arthropathy and we have a thin deltoid. What are you doing? And I think that if you have a thin deltoid and no cuff, you have to go close to the ground on prosthesis. But with a medialized, the humeral component should be medialized or reproduce the pathology, because it's very important to have the pathology, and sometimes you have a medialization. If you lateralize 1 centimeter, is a stiff shoulder on risk of pain. I think that you have to reproduce the pathology with the reverse. You have cuff tear arthropathy, you have a thin deltoid, distalize or not lateralize too much, because the risk is to obtain a stiff shoulder. And this is a question that today, how to evaluate the function of the deltoid? I have no answer. And this is a key point, because some surgeons say, this is a thin deltoid, this is a big deltoid. What is important? This is anterior fiber, medial fiber, posterior fiber. We don't know today. We evaluate the curve, but we cannot evaluate the deltoid. It's the reason why it's difficult to compare the results. The results are the same, is 60, 70 constant score, 70% function. Is very difficult today. And I think that in the future, the goal is to develop maybe a software to evaluate the function of the deltoid and the function of the cuff. And after, we can discuss about the degree of lateralization and distalization.
And there is another variable that you have to take care, that is the laxity or the stiffness of the patient. Yes. So some patients, they are very lax, and this hyperlax patient, they have fantastic results. And the stiff patient, in general, then they have very bad results despite whatever you do.
I agree with you.
Okay, so if I can add from engineering perspective, I think it's really important to try to lateralize the center of rotation as much as you can, because you have a semi-constrained articulation and you have a constant center of rotation. And in a normal shoulder, you have all the translation. So you have moving center of rotation. So you want to try to get it anatomically as possible with respect to center of rotation. Now, how much to lateralize or distalize, that depends on the patient and the muscle function. But from range of motion perspective, with external constraints, you want the center of rotation to be anatomically as possible. I know even with the lateralized glenospheres, it's still not out far enough as the normal center of rotation in an intact shoulder. So it's a staged process. And also, I think that there's always give or a take. But the most important part is, in order for shoulder to function, your muscles, your soft tissues have have to be in play, and that's why you want this anatomic reverse as much as possible.
Io volevo semplicemente, ho colto una
Yes,
certa...
maybe there is a difference between the positioning of the glenosphere between Valenti and Edwards. They are different. Dr. Edwards, in your presentation, you said that in order to avoid notching, you might lateralize the glenosphere, giving not so much importance to the inferior offset. On the contrary, years ago, we were taught that inferior offset was important in order to avoid notching. It seems to me that Philippe Valenti gives importance to the lateralization, but also to the inferior offset. So probably in order to avoid the inferior notching, but also the superior notching of the acromion. Edwards, can you confirm this? I mean, do you think it is sufficient in preoperative planning to lateralize, while it is not of fundamental importance to place the inferior glenosphere?
Yes. So what I did initially when I switched to a lateralized glenoid design was I actually did put it on the inferior portion of the glenoid. And then talking to Mark Frankel, he said, well, he puts it directly in the center. So I gradually started moving it up and up more. And then Jerry Williams and I were kind of putting it in between the center and where it would be inferiorly. And then we found, well, we might as well put it in the center like Mark. And then when we started looking at our postoperative radiographs, the ones that looked the best as far as the appropriate relationship of the humerus to the scapula were the ones that we put in the center. So that's why I kind of evolved to the center. Now, the other thing I said, well, maybe I'm going to get more notching, but with 6 millimeters or more of lateralization, I haven't seen notching. So it seems like the lateralization itself prevents the notching. So that's how I ended up where I am. I kind of went from inferior position to a little bit up to now dead center.
Perfetto, adesso ho una domanda per te, Pietro.
Perfect. A question for you, Pietro, and then we will ask all the other colleagues. As far as the subscapularis is concerned, you are among the colleagues who stress the importance of releasing the subscapularis to strengthen internal rotation, or maybe you say that there are already lots, there is already latissimus dorsi, teres major, etc., and we might have problems with external rotation. What is your approach when there is a good subscapularis to be repaired? Thank you, Giovanni. This is a very interesting question. Well, my idea is that it is important to try and have a reverse prosthesis with an infraspinatus and the subscapularis. When it is possible, I always repair it, unless there is a steep shoulder, a post-traumatic, very stiff shoulder. In that case, it could be a good idea to have a release of the unrepaired subscapularis. Philippe, what do you do? Subscapularis.
Yes, I think that it's very important, the subscapularis, for the strengthen on interrotation more than for the stability of the prosthesis. But it's the reason why don't lateralize too much, because if you lateralize too much, you cannot repair the subscapularis. And the subscapularis is a bigger muscle of the shoulder. And it's the reason why when I have no subscapularis, I do a pectoralis major transfer, and I have better results with pectoralis major transfers than no subscapularis. And I send the paper to GSES. I think that this is a very, for the balance of the shoulder, if you have a good teres minor and if you have no subscapularis, I think that there is potentially a polyethylene wear after 5, 10 years or 15 years. And I think that the balance is very important, and for the strengthen of internal rotation. Because to obtain internal rotation, you have to do retropulsion. This is the first movement. And sometimes it's difficult to do retropulsion, and after you do internal rotation. And some people put the arm on the back, but with a Gerber positive. And if you have a Gerber positive with a reverse arthroplasty, you cannot use very nice your internal rotation. And I check the Gerber test, the lift-off test. If the lift-off test is positive, I think that the subscapularis is not working very well. And many times the belly press test is negative, but the lift-off test is positive. With a lift-off test positive, the function is not so well in internal rotation.
Edwards, sottoscapolare.
Edwards, subscapularis. What do you do with the subscapularis with reverse anatomic prosthesis?
Yes, if I can repair it and get a relatively tension-free repair, I do. And I think as we move to the anatomic reverse, you should be able to repair it in most cases. But in certain circumstances, if the patient is terribly stiff and you can't get it over, then I do not repair it in that circumstance, because I don't think making a heroic effort to just get it tacked down, I don't think it will heal anyway. Does it make a difference? Perhaps. I think Philippe made very good points as far as functional internal rotation. But I don't think with a lateralized offset, it makes a difference in stability. I think it's more of a functional issue, not a stabilizing issue. Whereas if you look at a Grammont design, I think the subscapularis does add stability to that implant. So if I can repair, I repair. If I can't, I do not. I don't do transfers. I have no experience with that for that circumstance.
Giovanni,
Grazie.
posso fare una domanda, Giovanni?
Certo.
Can I ask a question, Giovanni? I'd like to ask you if you prefer to lateralize with metal or with bone.
Lateralization of the base plate.
If I can answer, I prefer to lateralize with the metal, because if you do by RSA, you have a risk of glenoid notch inferiorly to the bone graft, and you have a risk of potential non-healing of the BIORSA. And you remember that the progression of the BIORSA, at the beginning, it was a symmetric bone graft. Now this is an asymmetric bone graft.
Yes.
The superior bone graft is more important than the inferior bone graft. The reason why is that it's not to avoid a glenoid notch inferiorly. And I think that if you put inferior tilt with a metal, if it's not enough, you can put a bone graft superiorly. And I think that is, for the surgeons, is less risky for the future with the metal. And remember that Bradley used the Mark Frankel prosthesis, but this is a 2/3 sphere. And when you read the history of Grammont, one of the prostheses was a 2/3 sphere. And I think that Mark Frankel was a clever man, because he did a very nice copy of the one of Grammont prosthesis, because 2/3 sphere described by Grammont, and I think it's a very nice idea. And I understand very well why Bradley shifted to this prosthesis, because if you have a 2/3 sphere, it's not necessary to go inferiorly. 2/3 sphere, you can put center, and for the surgeon, it's very easy. It's not necessary to correct the deformity. You go in the center where you have a lot of bone, and you are sure that the fixation is good. And I agree completely with this concept.
No, that's great, Philippe. So actually, I still use a Grammont.
Yeah, the name of the Grammont prosthesis was La Trompette, correct?
Yes.
La Trompette.
Yes. It was the polyethylene humeral component that was cemented into place.
Yes.
Do you want to add something, Tai?
Yeah, I was going back to subscap repair and soft tissue management. I think simplest way to think about that, whether to repair or not, what you have is you need to, once you assess the patient, the force couples in the shoulder are very important. So I think your goal is looking at the force couples and what muscles they have left, and you adjust accordingly. If they have strong infrared teres, then of course, you should repair the subscap. Otherwise, you're going to have an unbalanced shoulder. So from fundamental perspective, it's just trying to maximize the function of the muscles that you have. So force couples are really important to think about in different planes.
Grazie, io vi ringrazio tutti, ho delle
Thank you. I'd
pressioni.
like to thank you all in Rome, but also in Milan. It's dinner time. So before everybody leaves, I'd like to take this opportunity to thank you for your prestigious participation. We're really happy to have had you. 4 friends of international renown. Thank you very much for your presence, and thank you very much for all that you have taught us. And I do hope that we will have the opportunity to meet live in Rome. Thank you very much. Goodbye.
Bye-bye.
Thank you.
Thank you, Giovanni. Good team.